1, 2,
And review 70-year-old female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep your heart again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
You know, usually when we talk about a medical diagnosis, there's this expectation of precision. It's almost like engineering.
Right. Yeah. Like it should be black and white.
Exactly.
Okay.
You break your arm, the x-ray shows that jagged white line, and the doctor just points at it and says, you know, there it is, broken.
It's binary. You look at the film, you see the fracture, you cast it. It's clean and, well, comforting because we really like things to be visible and easily categorized.
But then you step into the world of obstetrical nursing, and suddenly that x-ray machine is just, well, it's broken.
Oh, completely.
We are looking at a clinical landscape that is honestly pretty murky. I mean, you have 2 patients inside one body.
Yes, and they are communicating through a hidden organ, like placenta.
Right. And things can change from perfectly expected to a life-threatening emergency in the span of like a single heartbeat. So if you are listening right now, you are likely a nursing student, maybe a new orientee, or someone preparing to tackle their OB exams.
And you are entering one of the most dynamic, challenging, and honestly rewarding specialties in all of healthcare.
It really is.
Our mission for this deep dive is to sift through the massive stack of obstetrical nursing source material we have and apply the 80-20 Pareto principle.
Which is so needed because the textbooks are just huge.
They are massive. So we are going to extract the highest yield, most testable, and most critical clinical pearls. I am not here to read you a textbook.
Thank goodness.
I am here to help you pass your exams and, more importantly, to help you become a safe, prioritized future nurse.
And I am here as your enthusiastic study buddy, the one who loves taking these massive, overwhelming concepts and turning them into analogies that, you know, actually make sense.
And sitting across from you as well, I like to think of myself as your elite OB clinical mentor and exam coach.
So how exactly are we going to tackle this mountain of information today?
Well, we are going to set some strict ground rules right off the bat. We're going to focus relentlessly on safety, priority interventions, so think airway, bleeding, fetal distress, and those classic, tricky exam traps that test writers absolutely love to use.
Oh, they love a good trap.
They really do. We are going to separate the expected from the concerning, focus on what requires immediate follow-up, and build your clinical judgment so you aren't just memorizing random facts. You will learn to actually see the pattern.
Seeing the patterns instead of just drowning in a sea of flashcards. I absolutely love that.
It's the only way to survive nursing school, honestly.
So true.
Yeah.
So before we get into the dramatic emergencies of the delivery room, it makes sense to start with the chronological beginning of a potential crisis.
Right, the early stuff.
Yeah, what happens when the biological clock goes off, well, too early?
We have to start the preterm puzzle. Preterm labor and the medications we use to manage it. Let's look at the absolute high-yield core must-knows here.
Okay, lay it on me.
We define preterm labor as the onset of regular uterine contractions that cause actual cervical change prior to 37 weeks of gestation.
The key phrase there seems to be cervical change, right? Because you have to differentiate true preterm labor from Braxton Hicks contractions. I know a lot of people think like any contraction before 37 weeks is an absolute crisis.
That is a very common misconception. Braxton Hicks contractions might feel uncomfortable, like a tightening across the belly, but they lack a regular established pattern.
So they're just random.
Right. But most importantly, they do not result in cervical change. True preterm labor causes the cervix to shorten, soften, and dilate.
Okay, so it physically alters the anatomy.
Precisely. If a client comes in at, say, 32 weeks complaining of some cramping, you cannot just look at the tocodymometer on the fetal monitor, see some uterine irritability, and definitively diagnose preterm labor. You have to look for that physical cervical change.
Why does the uterus even do that? I mean, why practice with Braxton Hicks if it's not time for the baby to come out?
It is essentially the uterine muscle maintaining its tone. The uterus is a massive muscle, and it needs to be primed and ready for the marathon of labor.
Like stretching before a workout.
Exactly like that. Braxton Hicks increased blood flow to the placenta and helped maintain the structural integrity of the uterine wall. But when those practice runs turn into a coordinated, rhythmic, and forceful pattern that actually pulls the cervix open prematurely, well, we have a massive problem.
And looking at our sources, preterm birth affects about 10% of births globally.
It's incredibly common.
Yeah, it is a massive driver of neonatal morbidity. But here's where my understanding gets a little, fuzzy.
Okay, what's tripping you up?
The goal of treating preterm labor isn't necessarily to stop labor forever, is it?
If we look at the clinical reality, you are absolutely right. In many cases, you cannot stop the biological train once it has truly left the station.
So what are we trying to do?
The primary goal of tocolytic therapy, so the medications we use to slow or stop contractions, is actually incredibly modest. The goal is just to delay birth by at least 48 hours.
Just 48 hours? That seems like we are setting the bar incredibly low. I mean, if they're at 30 weeks, why aren't we trying to keep the baby in there for another 10 weeks?
Because the medications we use to stop contractions are not benign. They have severe side effects for the maternal client.
Oh, I see.
And furthermore, sometimes the body is going into preterm labor for a reason, like an underlying infection. And keeping the fetus in a hostile, intrauterine environment is actually more dangerous than just delivering early.
That makes a lot of sense. So why 48 hours specifically?
That 48-hour window is highly specific. It is exactly the amount of time needed to administer corticosteroids to the maternal client.
You're talking about betamethasone.
Exactly. Those 48 hours give the betamethasone time to cross the placenta and enhance the formation of fetal lung surfactant.
Which is crucial for breathing.
Yes. Surfactant is the slippery substance inside the alveoli of the lungs that keeps them from collapsing every time the baby exhales. Premature babies lack surfactant, which is why respiratory distress syndrome is a primary cause of death in preterm infants.
So we are literally just buying time to mature those lungs.
Buying time, that's the perfect way to phrase it.
It's like hitting the snooze button on a biological alarm clock. You know you can't sleep forever, you just need enough time to put on your armor, the betamethasone, before you have to face the cold, harsh day outside.
I really like that analogy. You are buying time for the armor. So as a nurse assessing a client who comes into triage, we need to separate the expected from the concerning.
Right, because we don't want to panic over normal pregnancy pains.
Exactly. Expected findings in the late second or early third trimester might include dull backaches or mild pelvic pressure as the baby grows. But what are the concerning findings that tell us this isn't just normal pregnancy discomfort?
Well, the sources emphasize a cervical length of 25 millimeters or less on a transvaginal ultrasound.
Yes, that's a huge red flag. A shortened cervix is highly predictive of preterm birth. The cervix is normally thick and long, acting as a physical barrier.
Like a tightly closed door.
Right. If it is effacing, thinning out to 25 millimeters or less, that physical barrier is failing, the door is opening. Another concerning finding and a massive exam focus is the fetal fibronectin, or FFN, test.
Let's unpack the FFN test because it seems like a giant trap waiting to happen on an exam. What exactly is fetal fibronectin?
Think of fetal fibronectin as a biological glue. It is a protein that physically binds the fetal amniotic sac to the maternal uterine lining.
So it holds everything in place?
Normally, yes, this glue stays intact and hidden. But if the physical relationship between the sac and the lining is being disrupted, like if there is inflammation or the cervix is starting to pull open, that glue starts to leak into the vaginal secretions.
So if we swab the vagina and find this glue, it means things are starting to break down.
Precisely. But here is the major exam trap you absolutely must avoid. The predictive value of the FFN test is heavily skewed.
Skewed how?
If the FFN swab is negative, it is incredibly reliable. A negative test means it is highly unlikely, like less than a 1% chance, that the client will deliver in the next 2 weeks.
Wow, less than 1%.
Yeah, so you can confidently reassure them, provide education, and send them home.
But what if it's positive? Does that mean the baby is coming today?
And that's the trap. A positive FFN test is not a guarantee that they will deliver. It just means the glue is disturbed.
Oh, I see.
They might deliver in 2 days, or they might go full term to 40 weeks. A positive test just raises your level of suspicion. You cannot definitively diagnose imminent preterm labor based on a positive FFN alone.
Okay, that makes perfect sense. Negative means you're safe for a couple of weeks. Positive just means, hey, we need to watch you closely.
Exactly. Keep a close eye on them.
So let's say they are exhibiting real cervical change and we need to hit that snooze button. Let's walk through the pharmacology, the big 4 preterm labor medications.
This is pure exam gold right here. The first one you will frequently see is terbutaline. It is a beta-2 adrenergic agonist.
Now, I remember from basic pharmacology that beta-1 receptors are in the heart. You have one heart, and beta-2 receptors are in the lungs because you have two lungs. So terbutaline is primarily targeting the lungs.
It targets the lungs to cause bronchodilation, which is why it's historically been used as an asthma drug. But here is the critical obstetrical crossover. The smooth muscle of the uterus is also packed with beta-2 receptors.
Oh, wow. I didn't realize that.
Yes. So when you give terbutaline, it relaxes the bronchial smooth muscle, but it also forcefully relaxes the uterine smooth muscle, stopping the contractions.
That sounds great for stopping labor. What's the catch? Because there's always a catch.
Always a catch. The catch is receptor cross-reactivity. While terbutaline prefers beta-2 receptors, in the high doses needed to stop labor, it spills over and stimulates the beta-1 receptors in the maternal heart.
Oh, no.
Yeah, it basically slams the accelerator on the maternal heart rate.
Which means the priority nursing assessment has to be cardiovascular. We have to check her pulse.
Absolutely. The strict, non-negotiable parameter you must memorize.
Right.
You must hold terbutaline if the maternal heart rate is greater than 120 beats per minute.
Hold if HR is over 120. Got it.
If you push this drug while she's already tachycardic, you risk putting her into a dangerous arrhythmia or even cardiac ischemia.
Are there any other major risks with terbutaline?
Pulmonary edema. Because it alters capillary permeability and cardiovascular dynamics, fluid can start backing up into the maternal lungs.
So we need to listen to her chest.
Yes. If your client on terbutaline starts complaining of shortness of breath, or you hear crackles in their lung bases, you stop the drug immediately and notify the provider.
Hold for heart rate over 120. Watch for crackles in the lungs. Okay, what is the second medication?
Nivetimur. This is a calcium channel blocker.
So going back to physiology, muscles need an influx of calcium to contract. If we block the calcium channels, the uterine muscle physically cannot fire and cramp up.
Exactly right. It inhibits calcium ion influx across the smooth muscle cell membrane. The uterus relaxes. But just like terbutaline, the medication doesn't only stay in the uterus.
It goes everywhere.
Right. What other smooth muscle in the body relies on calcium channels?
The blood vessels. So if we relax the blood vessels, they dilate, and if they dilate, the blood pressure is going to drop.
Yes. Maternal hypotension is the primary adverse effect here. Your priority action is checking the blood pressure before administering nifedipine.
That makes total sense.
You also need to teach the client to change positions slowly to avoid orthostatic hypotension. And do you remember the classic pharmacology dietary trap with nifedipine?
Oh, grapefruit juice. You have to instruct the client not to consume grapefruit or grapefruit juice because it inhibits the liver enzyme that breaks down the drug, leading to severe toxic levels of nifedipine in the blood.
Spot on. The test writers love a grapefruit juice question. Now for the third medication, which is an absolute heavyweight in obstetrics, magnesium sulfate.
Wait, magnesium sulfate? I always thought of magnesium as just like a daily vitamin supplement you take for muscle cramps or to help you sleep. Why are we giving a heavy metal IV drip to a pregnant woman in preterm labor?
It's a great question, and it's because intravenous magnesium sulfate is a potent central nervous system depressant.
Oh, it depresses the CNS.
Yes, it competes with calcium at the motor end plate, essentially blocking the transmission of nerve impulses to the muscles. In the context of preterm labor, it relaxes the smooth muscle of the uterus for tocolysis.
But the sources also emphasize that we give it for the baby, not just the mom.
Yes, and this is highly testable. If a preterm birth is deemed inevitable and imminent before 32 weeks, we run a magnesium sulfate drip for fetal neuroprotection.
Neuroprotection? What does it do for the baby's brain?
It stabilizes the cerebral blood vessels and reduces inflammation in the fetal brain, which significantly reduces the risk and severity of cerebral palsy in the premature newborn.
That is absolutely fascinating. But if it's a central nervous system depressant and we are running it systemically through the mother, aren't we depressing her nervous system too?
We are, and that is exactly where the danger lies. Magnesium sulfate toxicity is one of the most heavily tested safety topics in all of nursing.
So we need to be really careful with the dosing.
Extremely careful. If the magnesium levels climb too high, everything in the maternal body slows down dangerously until it simply stops.
I know there are very specific cutoff numbers we need to memorize for toxicity. Let's walk through what that looks like clinically.
Picture the patient. You walk into the room, and she's lethargic. You take your reflex hammer to check her patellar reflex, her deep tendon reflexes, or DTRs.
Normally, those should be a 2+B. Right.
Exactly. But if she's becoming toxic, those reflexes diminish because the nerve transmission is blocked. DTRs dropping to 1 plus or 0, meaning absent reflexes, is a massive red flag.
So absent reflexes. What about her breathing? If the muscles are depressed, her diaphragm won't work as well, right?
You're right on the money. You are watching for respiratory depression. Respirations dropping below 12 breaths per minute means the diaphragm is failing.
And how is the drug cleared from the body? Because if her kidneys aren't working, she's going to build up to a toxic level much faster.
Magnesium is excreted entirely by the kidneys, so you must meticulously monitor urine output. Oliguria, which is urine output of less than 30 millimoles per hour, tells you the kidneys are failing to clear the drug and toxicity is imminent.
Let me summarize those parameters because they are vital. DTRs of 1 plus or 0, respirations less than 12, urine output less than 30 millimoles per hour. And if we draw a blood level, what number are we looking at?
A therapeutic level is usually between 4 and 7 milli-UQL. A level greater than 8 milli-UQL is considered toxic.
If I see any of those signs, like if I walk in and she is breathing 9 times a minute and has no reflexes, what is the immediate mechanical action? Do I call the doctor?
You shut off the IV pump. You stop the infusion immediately.
Right away.
Yes, you do not call the provider first to ask permission. You stop the poison. Then you administer the antidote, which you should always have at the bedside when a client is on a magnesium drip.
Calcium gluconate.
Yes, because magnesium and calcium compete at the cellular level. Flooding the body with calcium overrides the magnesium blockade and restores nerve function.
Okay, so we've covered terbutaline, nifedipine, and magnesium sulfate. The final of the big 4 medications is the armor we discussed earlier, betamethasone.
Correct. Betamethasone is given intramuscularly to the maternal client, usually in 2 doses, 24 hours apart.
And this is the one that helps the baby's lungs.
Yes, it stimulates the type 2 pneumocytes in the fetal lungs to produce that life-saving surfactant.
All right, so let's shift our focus a bit. What happens if our tocolytic snooze button fails? Or worse, what happens if the protective bubble around the baby breaks before the client is even in labor?
Then we are entering the territory of PPROM, preterm, pre-labor rupture of membranes.
That sounds intense.
It is. The absolute must-know core here is understanding that the amniotic sac has ruptured before 37 weeks and before contractions have even started.
The amniotic sac is supposed to be this perfectly sterile, temperature-controlled, sealed environment. It's the ultimate physical barrier.
Exactly.
Once it breaks, the door is wide open for bacteria to travel up from the vagina, through the cervix, and right into the uterus.
And that leads to the most dangerous consequence of PPROM, Chorioamnionitis. This is a severe intra-amniotic infection.
So the uterus basically gets infected.
Yes, the fetal environment becomes a petri dish. The fetus can actually aspirate or swallow that infected fluid, leading to profound fetal sepsis, pneumonia, or meningitis before they are even born.
Wow, that is terrifying. So we need to know the difference between expected amniotic fluid and fluid that screams infection.
Expected amniotic fluid should be clear or pale yellow, and if you test the pH, it should be between 7.1 and 7.3.
Yeah.
It is slightly alkaline.
And concerning findings,
You are looking for fluid that is foul-smelling, or fluid that is green or yellowish-brown.
which indicates meconium staining, right? The baby has had a bowel movement in utero, which is a sign of severe fetal stress.
Exactly. But for chorioamnionitis specifically, there is a classic triad of infection you must look for.
Let me guess. Fever is one of them.
Yes, maternal fever greater than 38 degrees Celsius or 100.4 Fahrenheit, typically documented on 2 separate occasions.
Okay, what's the second sign?
The second sign is severe uterine tenderness. The uterus will be painful to palpation even between contractions because the tissue is acutely inflamed.
And the third sign?
Fetal tachycardia, a baseline fetal heart rate consistently above 160 beats per minute. In fact, fetal tachycardia is often the very first clinical sign of an intrauterine infection.
Really? Before the mom even gets a fever?
Yes. The baby's heart rate will speed up to try and circulate white blood cells in response to the invading bacteria, often hours before the maternal client ever spikes a fever.
That is a phenomenal clinical pearl. The baby will tell you there is an infection before the mom's thermometer does.
It's an early warning system.
So let's play out a scenario. A client comes into triage at 32 weeks and says, I think my water broke. I feel a gush of fluid. As the nurse, what is my priority action? Do I immediately do a vaginal exam to see if she's dilating?
Absolutely not. And this is a non-negotiable safety rule. If you suspect PPROM, you avoid digital vaginal exams unless birth is visibly imminent.
Wait, really? Why? I thought checking the cervix was a standard protocol when someone comes in.
Think about the anatomy. The vaginal canal is heavily colonized with normal, healthy flora bacteria that belong there. But the uterus is supposed to be sterile.
Oh, I see where this is going.
Every time you introduce a gloved hand into the vaginal canal to check the cervix, you are physically pushing that vaginal bacteria upward toward the open, unprotected cervix.
So you're causing the infection.
You dramatically increase the risk of ascending infection. We have documented cases where a perfectly stable PPROM patient develops raging Chorioamnionitis simply because too many providers performed vaginal exams.
Wow. You literally push the bacteria up the elevator shaft.
That's a great visual.
So if I can't use my fingers to check the cervix, how do I verify that her water actually broke? What if she just peed herself? Because let's be honest, bladder control at 32 weeks is minimal.
Very true. We use sterile speculum exams to visually inspect for pooling of fluid in the vaginal vault, and we use diagnostic tests on that fluid. The two classic tests you must know are the nitrazine test and the Fern test.
I actually have a memory anchor for the nitrazine test. The swab reacts to the alkaline pH of amniotic fluid.
Right.
Normal vaginal secretions are acidic, right around a pH of 4.5, but amniotic fluid is alkaline, above 7.0. So my memory hook is nitrazine turns blue for baby.
That is a perfect anchor. If the yellow nitrazine swab turns deep blue or blue-green, it is highly indicative of amniotic fluid. The other test is the Fern test.
How does that one work?
You take a swab of the fluid from the vaginal pooling, smear it on a glass microscope slide, and let it dry.
And then look at it under a microscope.
Yes, because amniotic fluid has a very specific concentration of sodium chloride and proteins. When it crystallizes as it dries, it forms a highly distinct branching pattern under the microscope that looks exactly like a fern leaf.
Okay. So we verified the water is broken prematurely. We suspect infection. We are anticipating orders for IV antibiotics, typically ampicillin and gentamicin. But looking at our sources, there is a massive exam trap regarding diagnosing this infection based on lab values.
Yes, the white blood cell trap. Let's look at the physiology of pregnancy. A normal, non-pregnant adult has a WBC count of roughly 4,500 to 11,000.
Right, the standard range.
But during pregnancy, the body naturally mounts a wild inflammatory response, and WBCs can normally elevate to 15,000.
Even without an infection.
Correct. And during the immense physical stress of active labor, it is entirely normal for the WBC count to spike all the way up to 25,000 or even 30,000 without any infection present at all.
And we just talked about giving betamethasone, a corticosteroid. Steroids are famous for causing an artificial spike in white blood cells.
Exactly. It's called demargination of white blood cells off the blood vessel walls. So if you get an exam question about a client with PPROM who has a WBC count of 18,000, you cannot automatically diagnose chorioamnionitis based on that one lab value.
It could just be the steroids.
Exactly. Elevated WBCs alone do not equal infection in obstetrics. You must look for the clinical triad, the maternal fever, the uterine tenderness, and the fetal tachycardia.
Don't let a high WBC count trick you if the patient is otherwise completely stable in a febrile. Okay, so once the water is broken, the clock is ticking on infection.
It is.
If labor isn't progressing adequately on its own to deliver the baby before infection sets in, the medical team has to step in to push the pace.
Which brings us to the concepts of labor augmentation and the risks of oxytocin. The first thing we need to clarify is the terminology. Students often confuse induction and augmentation.
What's the difference?
Induction is starting labor from scratch, creating contractions in a patient who isn't having any. Augmentation is intervening to help labor progress when it has already begun spontaneously but is stalled out. Contractions have become weak or spaced too far apart.
And the primary medication we use for both is intravenous oxytocin, commonly known by the brand name Pitocin. But the sources highlight that oxytocin is a high-alert medication that requires intensive one-to-one nursing.
Yes, you cannot take your eyes off this patient.
Why is it so dangerous? If oxytocin is just the synthetic version of the exact same hormone the posterior pituitary gland naturally makes to cause contractions, why do we have to monitor it so aggressively?
It comes down to the difference between a finely tuned physiological feedback loop and a blunt medical intervention. I want you to visualize natural labor.
Okay, visualizing.
The brain releases a tiny pulse of oxytocin. The uterus contracts, the cervix stretches, which sends a signal back to the brain to release a little more. It self-regulates.
It's a natural rhythm. And synthetic oxytocin.
Synthetic oxytocin running through an IG pump is like hooking a fire hose to the uterus. It does not self-regulate. If you turn the IV rate up too high, the uterus is forced to contract too forcefully, too frequently, and for too long.
But why is a super strong frequent contraction bad? Doesn't that just get the baby out faster?
To understand why it's bad, you have to understand the anatomy of placental blood flow. Think of the uterus as a sponge filled with maternal blood, and the placenta is absorbing oxygen from that sponge.
Okay, a blood sponge.
Every time the uterus contracts, the muscle fibers tighten and physically squeeze the maternal blood vessels shut.
So blood flow stops.
Exactly. During a peak of every single contraction, blood flow to the placenta briefly ceases. The fetus experiences a temporary normal decrease in oxygen. It's like the baby is holding its breath.
Which is why there needs to be a break between contractions.
Yes. In a normal labor, there is a crucial rest period between contractions, the relaxation phase. During this rest, the uterine muscle loosens, the blood vessels open back up, the placenta refills with fresh, oxygenated maternal blood, and the baby takes a breath, so to speak.
Oh, I see where this is going. If we crank the oxytocin fire hose too high.
You cause uterine tachycystole.
Tachysystole, that sounds bad.
It is. The clinical definition you must know is more than 5 contractions in a 10-minute window, averaged over 30 minutes. If the uterus is contracting 6, 7, or 8 times in 10 minutes, there is no relaxation phase.
So the sponge never refills with blood.
Exactly. You're effectively cutting off the baby's oxygen supply, leading to profound fetal hypoxia and acidemia.
That is terrifying when you visualize the mechanics of it. So expected findings on the monitor would be contractions every 2 to 3 minutes, lasting roughly 60 to 90 seconds, with a clear resting tone in between.
Correct.
Concerning is that tachysystole. What is the priority action if we see more than 5 contractions in 10 minutes?
This is a non-negotiable action. You stop the oxytocin infusion immediately.
Turn it off completely.
You not just turn the rate down by a few milliliters, you clamp the line and turn off the pump. You remove the stressor.
Okay, so we've established that oxytocin can suffocate the baby if we aren't careful. How do we actually know if the baby is holding its breath for too long?
We have to read the fetal monitor. The continuous fetal heart rate strip is our only window into the neurological and respiratory well-being of the fetus.
Let's break down reading the strip. What is considered normal?
The expected baseline fetal heart rate should be between 110 and 160 beats per minute. We want to see moderate variability.
Variability meaning it shouldn't just be a flat line.
Exactly. Variability is the beat-to-beat fluctuation in the heart rate. It should look slightly jagged. Good variability tells us the fetal autonomic nervous system is intact and oxygenated, and we want to see accelerations.
Accelerations are when the heart rate temporarily jumps up, right? Like when the baby moves.
Yes. Accelerations are always a good sign. They're the fetal equivalent of your heart rate going up when you jog up a flight of stairs. It proves the baby has oxygen reserves.
But deviations from that baseline indicate trouble. We already mentioned that maternal fever causes fetal tachycardia. What about the drops in the heart rate? The decelerations?
Decelerations are where clinical judgment is truly tested. When the heart rate drops in relation to the uterine contraction, tells you exactly what the physiological problem is. Let's look at the 3 main types.
All right, get me.
First, early decelerations. These mirror the contraction perfectly. As the contraction builds and goes up on the monitor, the fetal heart rate smoothly goes down. They hit their lowest point at the exact peak of the contraction, and they recover back to baseline right as the contraction ends.
What causes that perfect mirroring?
It is a mechanical vagus nerve response. As the baby is pushed down the birth canal during a contraction, their head is compressed against the maternal pelvis.
Oh, head compression.
Yes. This physical head compression stimulates the fetal vagus nerve, which temporarily slows the heart rate. Because it is just a pressure response, it is a benign expected finding. It just means the baby's descending. You do not need to intervene, you just document it.
Early equals head compression. Expected. What about variable decelerations?
Variables look very different. They are abrupt. They drop sharply, looking like V's or W's on the monitor strip.
Like a sudden cliff?
Exactly. They can happen at any time with or without a contraction. They indicate cord compression.
So the umbilical cord is being squeezed?
Yes, the umbilical cord is being physically squeezed.
Huh.
Maybe the baby is grabbing it or lying on it or the fluid is low. It temporarily cuts off blood flow, causing a sudden spike in fetal blood pressure, which triggers baroreceptors to abruptly tank the heart rate.
Variable equals cord compression. And the third type?
The most dangerous, late decelerations. These are subtle but ominous. They start after the peak of the contraction, and the heart rate doesn't recover until well after the contraction is completely over.
Why do they happen late?
It indicates placental insufficiency. The placenta is failing to deliver adequate oxygen. During the contraction, the maternal blood flow stops, as we discussed earlier.
Right, the sponge is squeezed dry.
Exactly. A healthy fetus has enough oxygen reserve to coast through that temporary pause. But a fetus with a failing placenta does not have reserves. By the time the contraction reaches its peak, the fetus has completely run out of oxygen. Hypoxia sets in, chemoreceptors detect the rising carbon dioxide, and the heart rate drops late in the cycle.
Late equals placental insufficiency. So when we see these non-reassuring patterns, especially recurrent late decelerations or severe variable decelerations, what are our priority nursing actions?
You must act systematically to restore oxygen to the fetus. We call this intrauterine resuscitation. Here's the exact prioritized sequence you need to drill into your mind.
Okay, step 1.
Step 1. Stop the oxytocin. If you are artificially stimulating the uterus to clamp down on the placenta, you must remove that stressor immediately.
Makes sense. Stop the stress. Step 2.
Step 2. Reposition the client. Turn them to their left or right lateral side.
Let's talk about the physics of that. Why does turning them on their side help?
Because of the maternal inferior vena cava. When a pregnant person lies flat on their back, the heavy, gravid uterus compresses the vena cava against the spine.
Which pinches the vein shut.
Yes. This traps blood in the lower extremities and prevents it from returning to the maternal heart. If blood isn't returning to the heart, it can't be pumped out to the placenta. Turning them on their side physically lifts the uterus off the vein, restoring cardiac output and placental perfusion.
And it might shift the baby off the cord too, right?
Exactly, which might relieve physical pressure on a compressed umbilical cord.
Stop Pitocin. Turn the patient. What is step 3?
Increase the rate of the primary 5E isotonic fluid. You open the fluids wide to give a rapid bolus.
To expand the maternal blood volume, which pushes more pressure into the placenta.
Precisely.
Yeah.
Now, what do you think about oxygen?
Honestly, it feels like oxygen should be step 1. If the baby is hypoxic, give the mom an oxygen mask.
And that is a massive, outdated exam trap.
Wait, really?
Yes. We used to throw a 10-liter non-rebreather mask on every client at the first sign of a dip in the heart rate. But modern evidence-based practice has changed this entirely. Oxygen is no longer the automatic first step.
Why not? If the baby lacks oxygen, why not supply it?
Because you have to fix the mechanics of the plumbing before you worry about the gas supply. Think about it. The umbilical cord is physically squeezed, shut-like, in a variable deceleration. Giving the maternal client 10 liters of oxygen won't help the fetus at all because the oxygenated blood cannot get past the kink in the hose.
Well, that makes so much sense.
You have to fix the mechanical perfusion problem first. You reposition the client to unkink the cord. You give fluids to fix the maternal blood volume. You only administer supplemental oxygen if those initial mechanical interventions fail to improve the fetal heart rate.
Fix the plumbing, then supply the gas. That is a brilliant way to remember it. So while light decelerations give us a warning that the placenta is slowly failing, sometimes the plumbing problems are sudden, dramatic, and require an immediate, rapid response.
We are moving into the red flag mechanical emergencies. Cord prolapse and shoulder dystocia.
Oh boy.
These are your absolute drop-everything emergencies. They are the highest stakes prioritization questions on any exam because when these happen, minutes literally equal brain cells.
Let's start with cord prolapse. The visual here is horrifying. The umbilical cord slips out of the cervix before the baby's head. When the massive hard skull of the baby comes down into the pelvis, it acts like a giant boulder crushing the cord against the maternal pelvic bone.
It instantly cuts off 100% of the fetal circulation. It is catastrophic if not managed within seconds. It most often happens right after the amniotic sac ruptures, especially if the baby's head wasn't fully engaged in the pelvis yet. The fluid gushes out like a waterfall, and it washes the lightweight umbilical cord down with it.
Put me in the room. I am the nurse. I do a vaginal exam right after the water breaks, and instead of feeling a hard fetal skull, I feel a soft, pulsating, rope-like structure. What do I do?
Your hand stays exactly where it is. You do not pull it out.
Leave my hand in.
Yes. You use your sterile, gloved fingers to manually push the baby's presenting part, the head OP, and off the umbilical cord. You are physically lifting the boulder off the hose.
Wait, I just stay there. How long?
You stay there until the baby is delivered. You will literally climb onto the bed, riding on all fours with the patient, with your hand inside the vagina, elevating the head. You will ride down the hallway into the elevator, into the operating room, and you will not remove your hand until the surgeon makes the abdominal incision for a stat C-section and pulls the baby out from above.
That is the definition of a mechanical intervention. I am the physical brace keeping the baby alive.
Exactly. The mnemonic in the sources for the surrounding actions is FROMI, fetal part elevated, rapid response called. Reposition the client to a knee-chest position or extreme Trendelenburg.
Let's explain knee chest. Why that position?
Because you want to use gravity to your advantage. If the client is on their hands and knees with their chest flat on the bed, their pelvis is the highest point of their body. Gravity will literally pull the heavy fetus back down toward the diaphragm and away from the pelvis, helping to relieve pressure on the cord.
What about pushing the cord back inside? If it's hanging out, shouldn't I just tuck it back into the warm uterus?
Never. That is a lethal exam trap. Never attempt to manually manipulate or push the cord back in.
Why not?
The umbilical vessels are highly sensitive. If you handle them, they will spasm, clamp shut, and completely cut off whatever remaining blood supply the fetus has. Just elevate the head, position the client, and call for help.
Okay, cord prolapse is terrifying. Let's look at the other mechanical nightmare, shoulder dystocia.
Shoulder dystocia occurs during the actual delivery. The baby's head delivers out of the vagina, but the anterior shoulder gets physically wedged behind the maternal pubic symphysis, the front pelvic bone. The baby is trapped in the birth canal.
Oh, man.
They cannot breathe because their chest is compressed and the umbilical cord is compressed inside.
The classic hallmark sign for this is the turtle sign, right?
Yes. The head emerges with a push, but because the shoulders are stuck when the push ends, the head retracts tightly back against the maternal perineum. It looks exactly like a turtle pulling its head back into its shell.
The sources mention a comprehensive mnemonic for the provider's actions. Camia, call for help. Apply suprapubic pressure. Movement of the arm. Position to hands and knees. Episiotomy. Elevate legs to knee chest. Rotate the fetus. But let's focus on the nurse. What are my specific immediate physical interventions when the provider yells, shoulder dystocia?
The two immediate nursing interventions are the McRoberts maneuver and applying suprapubic pressure. For McRoberts, you and another nurse grab the client's legs, remove them from the stirrups, and sharply flex the client's thighs back tightly against their own abdomen.
How does bending their legs back fix a stuck shoulder?
It alters the biomechanics of the pelvis. By sharply flexing the legs, you flatten the sacral promontory in the back, and it rotates the symphysis pubis slightly upward in the front. This simple positional change effectively opens the pelvic angle and increases the diameter of the pelvic outlet by several millimeters, which is often just enough space to free the shoulder.
Wow, just changing the angle of the bones. And what is the second action? Suprapubic pressure.
You literally stand on a stool next to the bed. You find the maternal pubic bone, and you apply firm, downward, CPR-style pressure with the heel of your hands right above the bone.
What is that doing anatomically?
You are trying to manually push the baby's stuck shoulder downward and forward, collapsing it slightly so it can slip under the bone.
Which brings us to the top exam trap for shoulder dystocia, the trick question about fundal pressure.
Yes. Test writers will try to trick you into applying fundal pressure.
Yeah.
The fundus is the very top of the uterus. Imagine the mechanics. The baby's shoulder is jammed solidly against the front pelvic bone. If you push down from the top of the uterus, what happens?
You just wedge the shoulder even harder into the bone, like trying to hammer a square peg into a round hole. You could fracture the baby's clavicle, or worse, you could rupture the mother's uterus from the sheer force.
Precisely. I correct this aggressively whenever I teach it. Never apply fundal pressure during a shoulder dystocia. It impacts the shoulder further. Always, always use suprapubic pressure.
So those are the massive mechanical traps. But as we continue our progression, we have to talk about what happens when the mechanical forces of labor or trauma cause internal structural failure. We need to talk about the hidden bleeding emergencies, placental abruption versus uterine rupture.
The ability to differentiate these two life-threatening events is a hallmark of elite clinical judgment. Placental abruption is when the placenta detaches from the inner uterine wall prematurely before the baby is born. Uterine rupture is when the actual muscular wall of the uterus tears entirely open.
I compare the uterus to an inflated balloon. Abruption is like the inner lining of the balloon peeling away, pooling blood inside the balloon. Rupture is the balloon actually popping.
That visual works perfectly. Let's look at the clinical picture of abruption. The hallmark symptom is sharp, sudden, tearing abdominal pain. The bleeding can be overt, meaning you see dark red blood pouring from the vagina, but it can also be highly deceptive. It can be concealed.
Concealed bleeding.
If the edges of the placenta are still attached to the wall but the center is peeled away, it traps a massive pool of blood inside the uterus behind the placenta. You might not see a single drop of blood externally.
But because it's bleeding massively inside that enclosed muscular space, the uterus reacts, right?
Yes. Blood is highly irritating to the uterine muscle. The uterus clamps down hard, and refuses to relax. The classic physical assessment finding is a rigid, board-like tetanic abdomen. It will be profoundly painful to the touch.
What causes the placenta to just peel off like that?
Usually it's extreme vasoconstriction or blunt force trauma. Cocaine use is a classic exam trigger for abruption because it causes massive sudden spasms of the blood vessels. Severe maternal hypertension or a motor vehicle accident are also prime risk factors.
Now, how does that clinical picture compare to a uterine rupture?
With a rupture, the balloon pops. The client will report an acute tearing pain, often described as something giving way. But the unique defining clinical sign here is a sudden loss of fetal station.
Loss of station.
The baby was at a +1 station, deep in the pelvis, moving down the birth canal. Suddenly, the uterus tears open, losing all its downward pressure, and the baby actually slips back up into the maternal abdominal cavity. You'll also often see referred pain to the chest or between the shoulder blades because the free-floating blood in the abdomen is irritating the diaphragm.
The sources note that a VBAC, a vaginal birth after a previous cesarean, is the highest risk factor for a rupture.
Yes, because the old surgical star on the uterus is a line of structural weakness. Under the intense pressure of labor contractions, that scar can give way.
So what are our priority nursing actions for both of these profound bleeding emergencies? Obviously, we are calling a rapid response and prepping for a stat C-section, targeting delivery in under 30 minutes. But what are we doing hemodynamically?
You're managing a hemorrhagic shock protocol. You must establish 2 large-bore IVs immediately. We need at least an 18-gauge catheter, preferably a 16-gauge.
Why do they have to be so large?
Fluid dynamics. You cannot push viscous-packed red blood cells rapidly through a tiny 22-gauge hand-off V. The cells will hemolyze, and the flow rate is too slow. You need a large pipe to slam aggressive fluid and blood volume replacement into the maternal circulation before her organs shut down from lack of perfusion. You will also anticipate sending a Kleihauer-Betke test to the lab.
Let's explain the Kleihauer-Betke test. It detects if fetal red blood cells have crossed the damaged placental barrier and entered the maternal bloodstream.
Exactly. This is crucial if the mother has an Rh-negative blood type. If fetal blood has mixed with hers during this traumatic tearing event, her immune system will recognize the fetal blood as a foreign invader and build antibodies against it. This will destroy future pregnancies.
So the test tells us how much ROGAM to give.
Yes. The Kleihauer-Betke test quantifies exactly how much fetal blood is crossed over, which dictates exactly how many vials of ROGAM the nurse needs to administer to suppress that immune response.
There is a classic exam trap here regarding bleeding that we must clarify. Distinguishing placental abruption from placenta previa. They both cause massive third trimester bleeding. How do we keep them straight?
It all comes down to the presence or absence of pain. Placental abruption is deeply, intensely painful, with that rigid, board-like abdomen and dark red blood. Placenta previa, where the placenta has implanted low in the uterus, completely covering the cervical opening, is classically characterized by sudden, painless, bright red vaginal bleeding. The abdomen remains soft and non-tender.
Abruption equals painful. Dark blood, rigid abdomen. Previa equals painless, bright red blood, soft abdomen. That is a rock-solid pattern to memorize. So, moving forward, not all complications result in a dramatic rush to the operating room for a C-section. Sometimes we have to manage the mess right there in the birth canal. Let's discuss meconium, malpresentation, and operative delivery.
Let's start with meconium. We touched on this earlier. When a fetus experiences significant stress or hypoxia in utero, their vagus nerve is stimulated. This causes their anal sphincter to relax, and they pass their first bowel movement meconium into the amniotic fluid.
Which happens a lot when they are overdue.
It's highly common in post-term babies past 41 weeks, as the placenta naturally begins to degrade and oxygen levels drop.
The fluid goes from clear to looking like thick green pea soup. And the major danger here is meconium aspiration syndrome. If the baby takes a deep gasp while still inside or immediately upon birth, they inhale this thick, sticky tar deep into their lungs. It blocks the airways and causes severe chemical pneumonitis.
Exactly. So what is the priority nursing action during labor if the water breaks and it's thick with meconium?
We try to dilute the soup. The provider might order an amnio infusion. The nurse assists in placing an intrauterine pressure catheter past the baby's head, and we continuously flush sterile, warmed, normal saline into the uterus.
Which washes it out.
It thins out the meconium, so it's less toxic if aspirated. And crucially, we absolutely must alert the NICU team to be physically present in the room for the delivery.
Perfect. Now, I want to highlight a major shift in evidence-based practice regarding meconium at the exact moment of birth. It is a highly testable area because the old rules have changed.
Right. It used to be that if there was meconium fluid, the moment the baby's head delivered, before the body even came out, the provider would stop and aggressively deep suction the baby's mouth and trachea to clear it out. But doing that is a track now.
Correct. We no longer perform routine intrapartum suctioning for meconium. The current evidence-based protocol dictates that if a baby is born through meconium and comes out vigorous, meaning they are crying lustily, have a heart rate over 100, and have good muscle tone, you do not perform deep tracheal suctioning. You just wipe their face and provide routine care.
Why did we stop? Wasn't it helpful to get the tar out?
Because aggressively jamming a suction catheter down the throat of a vigorous crying baby stimulates their vagus nerve. It can cause profound reflex bradycardia. Their heart rate plummets. We were actually causing more harm than good. You only intervene with deep suctioning and intubation if the newborn is depressed, floppy, not breathing, with a low heart rate.
That is a critical nuance for clinical judgment. Treat the patient, not just the fluid. Okay, what about malpresentation? Specifically, a breech baby.
The biomechanically safest way for a baby to navigate the pelvis is head first, with the chin tucked tightly to the chest. If they are breech coming down buttocks or feet first, the largest, hardest part of the body, the head, is delivered last.
Which is super dangerous.
This poses a massive risk for the head getting trapped or the umbilical cord prolapsing. Therefore, before labor begins, a provider might attempt an external cephalic version, or ECV.
This sounds somewhat barbaric when you describe it. They put their hands on the outside of the mother's abdomen, grab the baby through the uterine wall, and literally try to manually somersault the baby into a head-down position.
It is intense, and it carries significant risks. As the nurse managing this procedure, you must know that an ECV requires complete readiness for a stat C-section.
Just in case things go south.
While the provider is physically manipulating and dragging the fetus around inside the uterus, they can easily cause a placental abruption, or they can entangle and compress the umbilical cord. You are continuously monitoring the fetal heart rate, and if severe bradycardia occurs and doesn't resolve, you are rolling the bed straight down the hall to the OR.
Okay, the last mechanical intervention to discuss. Operative vaginal birth. This is when the provider uses forceps, or a vacuum extractor applied to the baby's head to physically pull them out.
The indications for this are usually a prolonged second stage of labor. The client has been pushing for 3 hours and is completely physically exhausted. Or there is a sudden, non-reassuring fetal heart rate drop, and the baby is low enough in the pelvis that a vacuum extraction is actually faster than prepping for a C-section.
The priority nursing action here that stood out to me in the sources seems almost too simple, but it is critical. Empty the bladder.
Yes, it is a mechanical necessity. If you are inserting large metal spoons forceps or a vacuum cup into the vaginal canal to forcefully drag a baby past the pubic bone, a full maternal bladder sits directly in the crossfire. A full bladder physically blocks the baby's descent, and it is at incredibly high risk for being crushed and ruptured by the instruments.
You definitely don't want a ruptured bladder.
You must insert a straight catheter to empty the bladder before the procedure begins. Furthermore, you must verify that the cervix is 100% dilated to 10 centimeters, the membranes are ruptured, and the fetal station is low, at least a +2, before forceps or a vacuum are ever applied.
And postpartum, after a vacuum delivery, the nurse must meticulously monitor the newborn for a cephalohematoma.
Let's connect the dots on why. What is a cephalohematoma?
It is a collection of blood pooling under the scalp, specifically caused by the intense trauma and suction of the vacuum cup tearing tiny blood vessels. And the secondary complication is what we really care about. As that trapped pool of red blood cells begins to break down over the next few days, it releases massive amounts of bilirubin into the newborn system. Their immature liver can't process it fast enough, leading to severe hyperbilirubinemia or jaundice.
That is an elite-level clinical connection. You are linking an intrapartum mechanical intervention directly to a postpartum neonatal complication.
So we've spent this entire time talking about amnion infusions, vacuums, rapid response teams, dropping heart rates, and stat C-sections. But in the chaos of all these highly clinical, highly aggressive interventions, there is a human being at the center of the bed experiencing what is likely the most terrifying, traumatic moment of their life. We cannot ignore the psychological reality of obstetrics.
Which brings us to the human element: grief, loss, and psychosocial support. This is arguably the most profoundly important aspect of nursing, and yet it is often the hardest to teach and the most uncomfortable to test. The high-yield core here is that obstetrical emergencies utterly destroy the client's perceived ideal birth plan. Whether it results in severe maternal physical trauma, postpartum PTSD, or the unthinkable tragedy of fetal loss, The psychological impact is shattering.
The sources mention a specific term, disenfranchised grief. When a miscarriage or stillbirth occurs, society often inadvertently minimizes it. People say things like, well, at least you're only 20 weeks, or you didn't really know the baby yet. But to that family, they didn't just lose a fetus. They lost their entire envisioned future. They lost the first day of school, the graduations, the whole identity of being that child's parent. Why does understanding this matter so much for the nurse at the bedside?
Because while the clinical interventions, the large bore IVs, the emergency meds, the chest compressions save the physical body, the nurse's communication, empathy, and presence are what save the patient's mind.
I'll be honest, when I read the protocol for fetal loss in the sources, it felt overwhelming. It's essentially the I didn't know what to say protocol, and that is exactly how I would feel standing in that room. I wouldn't want to open my mouth for fear of making the worst day of their life even worse.
That exact fear of making it worse is the #1 reason nurses physically and emotionally withdraw from grieving patients. We go in, check the vital signs in silence, and leave the room as fast as possible. But the evidence tells us that clients and families usually desperately want to talk about their baby and their experience. If you do not know what to say, your priority nursing intervention is to provide presence.
What does providing presence actually look like?
It means you actively listen. You pull up a chair, sit down at eye level, and you become comfortable with heavy, agonizing silence. You explicitly acknowledge their parenthood. You call them mom or dad. You ask, did you have a name chosen for your baby? And then you use that name. You treat the baby with the exact same dignity and reverence you would a living patient.
It's incredibly hard because medical training literally wires you to be a fixer. If the blood pressure is low, you push fluids to fix it. If the heart rate is dropping, you reposition to fix it. So when a tragedy happens that is absolute and permanent, standing there in silence without a fix feels like a massive professional failure.
But I need every future nurse listening to reframe that mentality entirely. Providing intentional presence is not a passive failure. It is an active, demanding, evidence-based nursing intervention. You hold the space for their grief, you do not make excuses for the medical team, and most importantly, you absolutely do not offer toxic positivity.
You mean the well-intentioned but horrific cliches, like everything happens for a reason, or God needed another angel, or you're young, you can always have another one.
Yes. Those statements are incredibly damaging. They invalidate the absolute reality of the patient's current grief. You provide clear, honest information about what is happening, and you simply validate their devastating reality. I am so sorry this is happening. I am here with you. That is the intervention.
Holding the space. It's a clinical skill just as critical as knowing how to push terbutaline or read a fetal monitor strip.
It truly is. It is what separates a competent technician from a true nurse.
Well, we have covered a massive amount of clinical ground today. We navigated the pharmacology of early warning signs, we broke down the physiology of fetal monitoring, we drilled the mechanics of the most intense bleeding and trapped baby emergencies, and we anchored it all in the profound psychosocial duty we owe our patients.
Let's distill everything we've discussed into the absolute most critical takeaways. If you only remember 5 things from this entire deep dive to take into your exam and your clinical practice, make it these 5 concepts.
Here we go. Number 1.
Number 1, magnesium sulfate toxicity. You are administering a CNS depressant. You must watch for absent deep tendon reflexes, respiratory depression below 12, and urine output below 30. If you see these signs, you stop the drip immediately and administer the antidote, calcium gluconate.
Number 2.
Number 2, intrauterine resuscitation for non-reassuring fetal heart rates, specifically late decelerations. Remember, fix the plumbing before you supply the gas. Stop the oxytocin, reposition the client to offload the vena cava, increase IV fluids to boost placental perfusion, and only then apply oxygen if needed.
Number 3.
Number 3, cord prolapse. The cord washes out before the fetal head, cutting off circulation. Never attempt to push the cord back in. Use a sterile gloved hand to elevate the presenting fetal part off a cord, reposition the client to knee chest to utilize gravity, and keep your hand in place all the way to the operating room.
Number 4.
Number 4, shoulder dystocia. The head delivers, but the anterior shoulder is impacted behind the pubic bone. Look at the turtle sign. Immediately initiate the McRoberts maneuver by flexing the maternal knees sharply back to the abdomen and apply downward suprapubic pressure to collapse the shoulder. Never ever apply fundal pressure as it will wedge the baby further.
And number 5.
Number 5, differentiating placental abruption from previa. Placental abruption is a premature tearing away of the placenta. It is characterized by deeply painful, dark red bleeding and a rigid, board-like abdomen. Establish 2 large-bore IVs immediately for massive fluid and blood resuscitation. Previa, by contrast, is painless and bright red.
I can guarantee those 5 points alone are going to save you on test day. And much more importantly, internalizing the why behind them is going to make you a fundamentally safe nurse when the alarms start ringing at 3 a.m.
That is the ultimate goal.
To leave you with a deeper philosophical takeaway rooted in the text we've been analyzing, we started this conversation by acknowledging that obstetrics isn't like clean binary engineering. It is messy, rapid, and unpredictable. We spent the better part of an hour learning how to execute a stat C-section in under 30 minutes, how to deploy rapid response teams, and how to use aggressive emergency protocols to snatch life from the jaws of tragedy. But the source material explicitly highlights the invisible toll of our clinical efficiency. The sudden, violent loss of the mother's perceived ideal birth plan, and the profound trauma that follows. As a future nurse, how do you balance the aggressive, mechanical, rapid-fire urgency required to save a physical life with the gentle, intentional, patient presence required to protect the psychological one?
It is the hardest balancing act in all of obstetrics, and mastering it is the true mark of an elite nurse.